go across the country to give these talks to educate the future medical professionals. And we are continually seeking to improve our work, and that's why we always ask for evaluations so we can continue to make it better. Normally in that presentation we go into the effectiveness in more detail, but Dr. Brahani asked us to go into effectiveness of family planning methods in more detail. So Dr. Stanford and I are going to do that. So again, as a disclosure, I have none. No corporate companies have contacted me in the last hour. Dr. Stanford served as a scientific consultant for Swiss Precision Diagnostics, which makes fertility monitors and pregnancy tests. So the objectives for this next talk is we're going to give an overview of the evidence for effectiveness of these methods for preventing pregnancy. We're going to present a summary of results of 2 comprehensive literature reviews on the effectiveness of FABMs. We're going to highlight some of the key issues when it comes to assessing pregnancy rates, identify future research needs, and discuss the implications for a Catholic health system. So I just want to check my time. It's 5 to 12. We're going to go till about 11:30, and then we'll go to the panel. All right. So again, if you're all here, you understand FABMs are based on observable signs of fertility. Let's talk, though, about the elephant in the room, the effectiveness of fertility awareness-based methods. You know, in our general intro talk for fertility awareness-based methods, which is basically an adaptation of the last talk, we don't really get to the effectiveness until later on in the presentation after we've described the methods. And one of my early mentors, Dr. Frank Dennehy, who is a family physician and residency director in Shenandoah Valley, is like, you have to talk about the effectiveness rates right up front, because that is the elephant in the room. And why is that? It is because of this statistic. The 24% failure rate, and I put that term in quotes, is the most commonly quoted statistic for the effectiveness of fertility awareness-based methods. And I'm here to tell you why that statistic is not accurate. Despite the fact that this is what is promoted by the CDC, FACTS in conjunction with Natural Womanhood actually developed a petition a couple of years ago to ask the CDC to quote effectiveness of FABMs based on individual scientific studies rather than this 24% rate. Why is that? This commonly quoted statistic reflects a combination of mostly outdated methods. Okay, so essentially what this was surveys that asked women what methods of family planning were they using when they got pregnant. And if they reported using any sort of a natural method, whether it was the rhythm calendar method, the Creighton model, the symptothermal method, the phases of the moon method, anything that did not involve, you know, artificial forms of contraception, they combined it into one. And what they discovered is, of those women surveyed, fully 86% reported they were using some sort of a rhythm calendar method. Now, again, what we presented in the last were all of the different modern methods, and that is not what the statistic reflects. When you look at the individual effectiveness rates of the modern fertility awareness-based methods, the typical use rates can be as low as 2% with the symptothermal method and the lactational amenorrhea method. The surveys that 24% statistic comes from is called the U.S. National Service of Family Growth. And the 24% typical rate is what's published in an article by Hatcher in 2011, and it's based on, I think it was the 1995 and 2004 surveys. Again, these are retrospective surveys where they surveyed women and asked them over the last year, what sort of family planning method were you using when you became pregnant? Interestingly, more recent surveys have found typical use pregnancy rates of natural methods to be as low as 15%, but that's not been published. So the CDC still goes with the 24% rate. Again, the limitations, these are all fertility awareness-based methods combined, the majority of whom were using the calendar rhythm. Reportedly, I dare you to ask a woman who says she's using the rhythm method to describe it for you. Most people who say they're using the rhythm method don't actually know what the rhythm method is or how it's calculated. The reason why they did not separate it out, their argument, is that there were not enough users of the individual methods to be able to quote it. And they only quote the typical use effectiveness rate, not the correct use. So it clearly paints us in a poor picture. This is what medical students and residents are learning, though. And this is exactly why we formed FACTS, so that we can go out there and give them information about the effectiveness rates. In terms of looking at evidence of effectiveness or of any medical treatment or application, and we pride ourselves on doing systematic reviews. There's only been one large systematic review up until the time FACTS did our study, and that was in 2005. It was a Cochrane review. At the time, they looked at only randomized controlled trials. There were only 2 available. Both had significant flaws, but they concluded based on limited data that unintended pregnancy rates for FABMs are high. let's talk about what are effectiveness rates. So what are unintended pregnancy rates versus effectiveness rates? The unintended pregnancy rate are the percentage, is the rate of pregnancies that were not planned. It's the inverse of the effectiveness rate. So if a method has a 5% unintended pregnancy rate, the method is, you can say, it's not with 100% scientific accuracy, but you can say the method is approximately 95% effective. Now, I earlier mentioned the term failure rate. I fully reject this term because when we say that a fertility awareness-based method has failed, what you have said is that this child is a failure. This is my unintended pregnancy. Like Allison, I was like, oh, it's day 8, like it's fine. I said to my husband, like, there's maybe 1% chance. I'm 42. What are the chances? Well, here were the chances, and it was, like Allison said, it was the greatest gift that we have ever been given, and I do not want to label my child as a failure from the moment of conception. So I prefer the term unintended pregnancy rate. Now, let's talk about effectiveness. That's a little bit odd. So I'm going to look at method effectiveness and perfect or correct use effectiveness. And it's important that you understand what these methods represent when we're discussing them. So the method effectiveness is how effective the method could potentially be. With both the method effectiveness and the perfect or correct use effectiveness, the numerator is the same when you're calculating it. It's all pregnancies that occurred when the method was used correctly to avoid pregnancy. So if the couple was following the rules of the method exactly as the method was designed, and they still got pregnant, those are pregnancies that occurred during correct use. When calculating the rate of the method effectiveness, though, the denominator is all cycles or months of use. So I use the example, let's assume there were 10 pregnancies that occurred with correct use of the method in a study of 1,000 cycles. So the method effectiveness would be 10 divided by 1,000, or 1%, so it would give you a 1% unintended pregnancy rate, or a 99% effectiveness rate of the method. With perfect use, that is when the couples used the method perfectly, used it correctly. And you look at the cycles when the method was used correctly. So again, if you have 10 pregnancies that occurred with correct use, but in that study with 1,000 cycles, only 250 cycles were used correctly, the perfect use rate would be 10 divided by 250 is a 4% unintended pregnancy rate, or a perfect use rate of 96%. Does that make sense? So, no, no, that does not make sense. So if the method is used, the potential overall effectiveness rate of the method is 99%, but when it's used correctly with correct use in a study, it's a 96% effectiveness rate. Okay, good, I'm getting a nod. Okay, what is important to note is that there have been relatively few studies of both fertility awareness-based methods as well as of contraception that have actually calculated the perfect use correctly. Now, let's also talk about typical use and perfect use pregnancy rates. So typical use is when couples use this in real life, in real world. How many of you have been given an antibiotic and told to take it? I literally have a patient, I have a direct primary care practice house call, so I had a patient text me or email me, and I'm prescribing her Keflex for her cellulitis, and I'm like, it's 4 times a day for 7 days. I'm pretty sure she's not going to take it 4 times a day for 7 days. I mean, everybody forgets something. So that's the typical use. When you're calculating typical use, you want to look at all pregnancies that occurred when the method was used correctly. So we had those 10 pregnancies, plus when the method was used incorrectly. Okay? So let's assume there were 10 pregnancies that happened when the method was used correctly and 70 when they didn't use it correctly. So we have a total of 80 pregnancies. Again, if we're looking at 1,000 cycles, that would give us an 8% unintended pregnancy rate, or a 92% effectiveness rate with typical use. What's important to note is the difference between that perfect use rate and the typical use rate reflects how difficult the method may be to use. So if a method's typical use rate is pretty close to the perfect use rate, the method is likely easy to use. So, but if it's bigger, if the correct use rate, perfect use rate is 96% and the typical use rate is 80%, that method's probably really hard to use in real life. Does that make sense? So, the perfect use rate, again, is when the method is used correctly and consistently to avoid, and again, it's the number of correct use pregnancies over the number of cycles when the method was used correctly. Now, one other thing I want to talk about is what do we use for the denominator for typical use? And this is going to come up when we talk about the differences between the FACS review and the Stanford review. So commonly what is used is we look at the typical use over all cycles. So if you recall, I said if there were 80 pregnancies, both correct and typical use pregnancies, and this happened in 1,000 cycles, we talked about the effectiveness rate would be about 92% effective. Well, some would argue if couples aren't having sex in a cycle, you shouldn't count those cycles because they're not exposed. You should only look at the typical use when the couples have documented having sexual intercourse. Research shows that about 80 to 90% of couples will have sex at least once a cycle. So let's assume that in this study of 1,000 cycles, there were only 800 cycles when the couples had documented sexual intercourse. The difference in the effectiveness rate, as you can see, is not that dramatic, right? So if you're looking at all cycles, it's 92%. If you're looking at cycles where the couples had documented intercourse, it's about 90%. I bring this up because this is going to be this is part of a larger conversation and debate we need to have. The FDA recommends when you're looking at effectiveness rates of family planning methods that you should actually only look at it when couples have documented sexual intercourse, again, because of potential exposure. Now, I would argue, I don't think you need to actually have sexual intercourse to be tempted and to have that potential exposure. I think it's fair to look at all cycles, but some would argue, no, we need to look at cycles where they've only had documented sexual intercourse. The other issue with that, though, is not everybody documents when they had sexual intercourse. And couples that are using fertility awareness-based methods and have been using them for years, we're lucky if they keep documenting through, ovulation. I mean, typically by the rise, day 3 after the temperature rise, like the chart goes in the drawer and it's not to be seen for another month. And if that's when couples are having sexual intercourse, those instances may not be documented. So that was the elephant in the room, looking at the effectiveness rates. I just want to make a point here. In order for these methods to be used effectively, there's a difference between fertility awareness-based methods and conventional forms of birth control. Fertility awareness-based methods really require patient engagement and behavior change. And I argue, as family physicians, I think we are well suited to support patients because we support our diabetics in modifying their diet and increasing their exercise. But in order for fertility awareness-based methods to be used effectively, I think there are 3 key characteristics. First and most importantly is you need to learn this from a trained instructor. Again, part of why we did the app study is because we were discovering so many women that were learning to use a method with an app. Creighton, for certain, has the largest number of trained instructors across the country that teach these methods, but many of these methods have trained instructors. So I think 1, learning from a trained instructor, 2, being motivated. I mean, women, you may be a lot more motivated to lose weight in, say, April, May, and June, then you may come September, October, November. I mean, what is your motivation? For my husband and I, we had serious reasons to avoid after the birth of our second child. So we were very motivated, and that affected our decisions, when we were intimate. So motivation is important. And third, the support of a partner. I mean, the reality is, as Allison pointed out, fertility awareness-based methods are a shared responsibility. And if you have really strong reasons for avoiding a pregnancy, but your spouse does not, that may make it more difficult to use the method effectively. So the reviews that we're going to look at are 2 reviews that have been done within the last decade. So Dr. Manhart and I, as well as a number of other physicians, did a review that was published back in 2013. What we did was look at fertility awareness-based methods that was published since 1980. Last month, 2 months ago now, Dr. Stanford, along with colleagues Dr. Arrudia, Chelsea Polis, and a couple of other folks from the Reply OB/GYN clinic, did a study looking at a systematic review, looking at fertility awareness-based methods, studies that have been published since 1920. How old was they went all the way back. So these are the 2 studies. The FACS study is currently available for download on our website, and then the Arrudia study is here as well. So let's look at what the reviews looked at. So again, both studies did a systematic search of the literature. For the FACS study, we only searched 1 database, the Medline database. The Arrudia study searched at 4 different studies. The inclusion criteria for effectiveness studies to include were similar. We included prospective studies that couples were using fertility awareness-based methods specifically to avoid pregnancy for at least a year. We did not look at LAM studies specifically. For our review, the Manhart review, we looked back at studies since 1980. The idea being, well, prior to the 1980s, there may have been methods that were done that are no longer available, and or there may have been some modifications to the rules. So if you're looking at the Billings method from the 1960s versus the Billings method from the 1990s, it may not be exactly the same. So the criteria that we used to include the studies were the same. We also used similar quality criteria. But where we differed in our reviews was how we weighted the criteria. So FACTS referred to what we called critical criteria. In the Aredia study, they referred to it as high quality criteria. There are about 12 criteria for each study, and these were the domains. We looked at, were these women and couples that were sexually active and of normal fecundity, meaning that, they didn't have any issues with low fertility, and the studies had to have clearly stated inclusion and exclusion criteria for both men and women. Were these studies prospective? Were these large studies that we were able to make strong statistical conclusions? In the Manhart study, we rated it high if there were at least 200. In the Aredia study, it was at least 50. Teaching, did the study indicate if the teaching was in standardized? Same thing with the Aredia study, although they required more stated in the article itself with regards to teaching. No learning phase, meaning did they start looking at the effectiveness as soon as the person enrolled in the study, not 3 months after they had the opportunity to learn? Because in real life, if a couple is starting to learn how to use the method and it fails within the first month, it's important to be able to recognize that. Follow-up, were these patients followed for at least 12 months? And if they dropped out, do we know why they dropped out? And if there was dropouts, were there a lot of dropouts or were there few dropouts? And then we looked at statistical analysis in terms of, life table analysis. Pregnancies reported, did they have a system for classifying and reporting pregnancies? Pregnancy intentions. One of the interesting things about our study, when we did our review that I noted, the interesting difference between the symptothermal method study that was done by Frank Herman and the Billings study that was done by the Indian Task Force is they looked at pregnancy intentions in the symptothermal study at the beginning of every cycle. In the Billings India study, they looked at pregnancy intentions at the beginning of the study. And they didn't take out couples 6 months in who may have changed their mind. So that's why I say when you're looking at effectiveness rates, you can't necessarily compare them apples to apples. Typical use, again, did they calculate it correctly? Same thing for correct use, which we just reviewed. And then with these studies approved by a local IRB. We had some additional criteria in our Manhart study. These were not our critical criteria, but it helped in the scoring if they used multiple or diverse populations, if they provided information about their sexual activity, whether or not they used barriers, did they document sexual activity. We looked at the different populations and coital frequency, and then attrition. And again, for both studies, it was important that the dropout rate was less than 20%, and there were reasons documented. So there was similarity in the criteria, but what differed was in the weighting. For the critical criteria in the Manhart study, in order for the study to be considered a high-quality study on the Manhart criteria, they had to have a positive score on all of the critical criteria. So for the criteria, they could have scored a 0 or a 4, and in some cases a 2. So with IRB, it's like you have IRB approval, it's a 4, you don't, it's a 0. With some of the others, they could earn 2 points. And so they had to have a positive score on all critical criteria, and the total score needed to be at least 40 points, which would rank them as a level 1 or a high quality study according to the Manhart FACTS study. And these were the only studies that we report. This is the studies that we quote in our effectiveness rates. With the Aredia study, they also had 13 criteria, and they rated them on high, moderate, or low. In order for them to identify a study as a high quality study, the study had to score high on every single criteria. So if they scored an 11 out of 13, it was not considered a high quality study. They had to score a low on any one of the criteria in order for the entire study to be classified as a low. All the others were moderate. So in the end, with the Aredia study, all of the studies that they evaluated, there were no high quality studies. There were some low quality, but the majority were within the moderate category, but it varied quite significantly. So in the end, Manhart et al. Reviewed 29 studies. 11 studies were rated as a level 1 or a high quality study. In the Aredia study, they reviewed 53 studies. 0 studies met criteria for high quality. 21 met criteria for moderate quality. And 32 met criteria for low quality and were not reported. So this is the table of effectiveness that FACS uses in all of our studies, and we have updated this to include a category for the ranking of the Arudia study. And as you can see, for almost all of the FACS studies that rated a level 1, what we did is we looked at the Arudia study. Again, if they scored anywhere from, if they were ranked moderate, the scores typically ranged from like 3 to 11. We looked at like what were the higher moderate versus the lower moderate. So if they scored a 7 or above on the moderate, we considered that a moderate plus. If they were 6 or below, it was like a moderate negative. So the higher moderate quality studies of the Arudia actually match up pretty well with our level 1 high quality studies here. So I added natural cycles in at the bottom. We did not actually review that. FACS did not review it in our initial review. We did do a review at this time, and it would rank as a level 2 in ours, so a moderate quality, and it's a lower moderate in terms of the Arudia study. I added that in because of all the buzz now, since that app has now been approved. I think it's important to recognize, just because it's widely available doesn't necessarily mean it's a great product. I think it's just important for people to recognize that. Questions on this table? It's a lot. We've got medical updates that are out there. I'm at halftime, so I've got to move it along. So this is from the Arudia study. Again, this shows their moderate and low quality studies. There were 21 moderate, 30 low quality. For each of the methods, with the exception of the Creighton model, and I'm going to let Joe speak to that, there was at least one or more moderate quality study that were done. Now, what I want to talk about next are the typical use pregnancy rates of new users based on the Arudia study. So this looks at the typical use rates. You can see at the top, they start with standard days and then cervical mucus methods, Billings, symptothermal, and Marquette. Again, Creighton is not on here because it was not considered to be of moderate quality. What I like to point out is, the effectiveness rates here range from as low as 2% with symptothermal and Marquette to as high as, over 30% with one of the Billings and the Thyma method, which, has anybody here ever heard of the Thyma method? Anyone? Okay, me either. Apparently that was a method, it was like kind of a splash in the pan in like 1980. But I'm amazed that they actually had a couple studies that they could look at for that. But what I like to point out is that when you actually look at their reviews based on the FACS review, the high quality studies, this is the yellow arrows point to the one where there's similarities. And what you can see is that for the high quality studies or the moderate plus quality studies, the effectiveness rates, again, range from about 2% unintended pregnancy rates to about 24%. Okay? Perfect use rates, again, the yellow arrows highlight the ones that were in the FACS study as rated as high quality, as well as the Arudia study rated as like a moderate high. So with perfect use rates, the effectiveness of these methods range from about 1% with the symptothermal method to about 3.5% with the standard days method. Persona is a fertility monitor, which this study based on Persona was an older study. They now have a new monitor. So we had not reviewed that. So in summary, with Sensiplan, which is a symptothermal method, and Marquette with monitor have the lowest typical and perfect use rates, ranging from about 2 to 7% with typical use and less than 1% with perfect use. For other methods, typical use pregnancy rates range generally from 9 to 25% in the first year, and most within 10 to 15%. So again, nowhere near the 24% that medical students consistently learn day in and day out. The strength, most methods do have multiple studies. Many of these studies have been done across the world, not only in the United States. In fact, very few have been done in the United States. The limitations, there is opportunity for improvement in quality and quantity of FABM studies. I think the only thing is lacking is not interest and motivation among the researchers. It's funding to be able to do this research. The high quality criteria proposed by Arudia, I would say the criteria are similar to the FACS criteria. It's the scoring on those criteria are more stringent than used in many contraceptive studies. And I'm going to conclude with this before handing it off to Joe. After FACS did our review of fertility awareness-based method studies, we worked with 2 of our student ambassadors, our FACS student ambassadors, to adapt our criteria for reviewing fertility awareness-based methods of spectrum studies to look at effectiveness studies of birth control pills. We only went back to 2000 in terms of looking at the effectiveness studies of birth control pills. There were 47 studies published in that time. And of the 47 studies, only 5 met a level 1 criteria. And of those 47 studies, only 1 study actually documented sexual activity, sexual intercourse. So even though the FDA recommends that when calculating typical use, most studies don't actually track that information. I'm going to pass it off. This.
Okay, it's good to be here. I'm going to go into some more details of some of the issues that are important to address as understanding the context and the interpretation of effectiveness. So many, in fact, I might venture to say most of the service delivery systems out there for fertility awareness or natural family planning have not done a use effectiveness study of their own. They rely on other studies for evidence of their effectiveness. And this is a common issue, of course, in medicine or healthcare generally. How much can you extrapolate from one study to another setting? And how much can you change before you change the results that you get? So, for example, Couple League in the United States is the largest provider of symptothermal. They don't have a study of their own effectiveness. Now, they do, however, try to adhere to the German protocols and instructions that are used by the German symptothermal group, which did publish a study. So you have to look at that and say, well, can we extrapolate that? And then, for example, you could. So that's different. Somewhat different teaching materials. They aren't using exactly the same materials. How much can that be? How much can you extrapolate from that? How about if you adapt or modify the chart? So Family of the Americas does a ovulation method that's similar to, but not the same as Billings. Is that going to have the same effectiveness? FEM claims they've developed their methods based on Billings, but they have a completely different charting system, completely different teaching system. Can you trust that the Billings methods will apply to FEM? Online platforms. So if you take a method and you put it on an app or an online platform, are you going to have the same effectiveness? And there's some of the apps that do symptothermal. They claim that they use the same basic approach, but and then one of the really popular systems that's been around a long time, Taking Charge of Your Fertility. It's a book and now it's a website and an app. That's a popular secular fertility awareness method. Says it quotes the German study, but they're doing things quite differently. But I think most important, so all these differences in teaching and how you adapt the rules, how are they going to affect the effectiveness rates? If it's not studied, we don't know for sure. But the most important one is different populations. And I'm going to go into that in a little more detail. Because that is if you don't know the population you're studying and characteristics of them, I would argue you really can't compare pregnancy rates for behavioral methods in general, but particularly fertility awareness or natural family planning methods. And in particular, I think the typical use pregnancy is a range. And it's impacted by demographics, motivations, as Marguerite mentioned, motivation is a key factor for effectiveness, and behaviors as well. And I think that these are as important, or in some cases more important, than the method. So let me give you a thought experiment. Let's say that you have 100 recently married couples in their mid-20s with good economic conditions who want 3 to 4 children and are using a symptothermal method. And then let's compare that to 100 married couples in their 30s and 40s who feel that their family is complete, they have challenging economic circumstances, and they're using a mucus-only method. Which group is going to have a higher total pregnancy rate and a higher unintended pregnancy rate? And does that reflect the method itself? Or does it reflect the motivations and conditions of the people using it? That's just a thought experiment to think about. So when you look at the study out of Germany, or you look at a study out of India, or you look at a study out of the US, you have to think about who are you studying, what are their motivations and circumstances, as much as you do the method itself. So here's an illustration of that comes from John Marshall. this is a basal body temperature method that I don't think hardly anybody uses a temperature-only method anymore, but they were using this in London and later Greater London area in the UK in the 50s and 60s. And these are Pearl rate, but you can think of them as sort of similar to percentages. And the pregnancy rates for the women ages 20 to 24 were 28% approximately, think of it that way. 35 to 39, less than 1%. And that isn't all biology. It isn't this, the women age 35, 39 are like that much less fertile than the women 20 to 24. It's actually mostly not biology because most of those women had, almost all of them had prior children. It's motivation and characteristics of how they're, who's more motivated to use the method to avoid. Here's another example from the recent randomized trial that Richard Fehring did in the Marquette model. He looked at the mucus-only version of the Marquette model and the monitor-only version of the Marquette model, and they had similar numbers of women in each group. The perfect use pregnancy rates were not statistically different from the two groups. The typical use pregnancy rates were statistically different, 3 times. Anyway, this is 3 times 18 versus, well, not quite 3 times 18 versus about 7 for the mucus versus monitor group. But then they also did an intention to treat analysis, and this was based. Okay, so the difference here is the typical use rate. If the women said at any point they did cycle by cycle, if they said, well, now we're going to use the method to conceive, they were dropped out of the analysis. But intention to treat, they were not dropped out of the analysis. So basically it's a total pregnancy rate. And so in that group, there is not as much difference between the mucus and monitor group. So you can either hypothesize here that something was somehow, just by chance, in a randomized trial, there were so many more women in the mucus group, in the monitor group that decided they wanted to get pregnant and then did, and women in the mucus group that just didn't decide but they got pregnant anyway, or there's something else going on. So you've got to look at underlying motivations and issues. So what is unintended pregnancy? How do we define it? Well, it's an imperfect concept, and I want to walk a fine line here, because I don't think it's a worthless concept, but it is a concept you have to understand the nuances of, and I don't think it's actually the best concept for fertility awareness, but it's a concept we're kind of stuck with in terms of people understanding it across the range of family planning methods. It's based on the stated intention to conceive. It doesn't indicate what the underlying motivations are, and it really doesn't fit the way some couples use fertility awareness. We heard 2 anecdotes. We heard 2 anecdotes this morning of persons who said, well, it's not so bad if we get pregnant, and we don't think we will, and we'll take it. We'll see what happens. That's not what's the unintended pregnancy is supposed to be. You plan, you decide we're going to get pregnant or we're not, and this kind of in between. Well, we'll see what happens is where a lot of couples actually live, but it's not accounted for by this concept of unintended pregnancy. So we did a study to illustrate this. We did a study of a few years ago of a subcategory of unintended pregnancy, mistimed. In other words, they said the pregnancy happened earlier than they wanted. And this was a qualitative study. And these are 4 different mistimed unintended pregnancies and the quotes from 4 different women. One of them, we planned it. We weren't expecting it quite so soon, but we were hoping for it. We were excited. So basically it was unintended because they had not said it was going to happen right then. They thought it would be a couple months away. The next one is, I have mixed emotions. We tried, so I guess in a way as planned, I would just tell them I want a baby. The next one, we're shocked at first. I thought the birth control would work. And the next one, it isn't wanted. I'm getting rid of it. And all of these are all considered unintended pregnancies, but they're obviously not all the same. So just this is why Dr. Hildreth, when he developed the evaluation system for the Creighton Model Fertility Care System, decided not to, at least this is my understanding of why he decided not to use the standard unintended pregnancy type of classification, and to base it on couple behavior instead of prospectively stated intention. So basically in the Crate Model Fertility Care System, as with any fertility awareness-based method, a couple can define each day as fertile or not. And if it's fertile, they have intercourse on a fertile day, that is a behavior that is oriented towards possibly getting pregnant, whether or not they intended, quote, to get pregnant or not. And there's another piece of it as well, and that is whether they're consistently observing and charting or not. I think this is a very, an approach that does in some ways fit better for some couples. I'm not saying it's going to fit the way everybody thinks about it, but it does fit better for some couples who use fertility awareness methods or natural family planning to think about how they might actually use it, whether they take that responsibility for their fertility in that way. And of course, so based on whether there's intercourse on a fertile day or not, or if there's intercourse on a fertile day, or if there's kind of inconsistent charting and not being careful and observing to be able to be confident about the fertile days, those are called achieving related behavior. And there's been a lot of misunderstanding over the years about this, where and some of it comes from both sides from all different sides of how this has been looked at. But achieving related behavior is not the same thing as unintended intentions. It's just a couple's understanding and knowing whether they are using a day of fertility or not, whether or not they intend to get pregnant. So great model studies use this concept of achieving related behavior, not the concept of unintended pregnancy. And to compare across studies, the review article by Rudy et al., in which I participated, it did not include the Crate model studies because they did not have that measure. They did not have the unintended pregnancy measure. And to illustrate this a little bit more, how intentions and behaviors are correlated in humans, but not perfectly correlated. This is from a recent study that we're still working on the analysis from, and we've published one paper, and another one's coming out from a Crate model study called SEBA. But this is in the SEBA study, we did something that is not standardly done in the Crate model studies, and that is at the beginning of each cycle, we asked each couple to indicate whether they plan to conceive in the next cycle. They weren't sure, they were going to avoid, or they were going to abstain. And the reason we had the abstain, primarily the reason we had the abstain option, was we had 40% of the couples started the study when they were engaged. So you can see that what we have here is percentages of behaviors by their prior stated intention. So you can see of those who had stated they wanted to achieve in the next cycle, over 60% had intercourse on a fertile day, but not 100%. Of those who said they weren't sure, it was about 45% intercourse on fertile day. Of those who said they were going to avoid in the next cycle, 25% had, or 26, something like that, had intercourse on a fertile day. Of those who said they were going to abstain, 9% had intercourse on a fertile day. That's any intercourse with or without barriers. We also did something else in the SEBA study that has not been previously standardly done in Crate model studies, and that is we asked them about whether at the beginning of each cycle, we asked them if they used a barrier withdrawal in the prior cycle. And about 11% of cycles overall had some barrier withdrawal use. And any of you know the Crate model, you know that's not part of the system. It's not taught that, not encouraged in the teaching. But that's the reality we live in, society we live in. People coming to these systems have a lot of other influences on them, of course, and a lot of other inputs, and 11% of cycles, they did use barriers of withdrawal. And you can see that also correlated somewhat with the stated intentions. So again, my point here is that behaviors and intentions, there's a correlation, but it's not a perfect correlation. So I think we really need to look at our underlying assumptions when we look at pregnancy rates with fertility awareness. Is it realistic to expect couples who wish to avoid pregnancy to chart consistently and abstain on fertile days? I think most of us would say yes. But a lot of people a lot of contraceptive researchers might not agree with that. If some couples cut corners or take chances, does that necessarily mean that FABM is too hard? I would make one amendment to what Dr. Duane said earlier about the gap between a perfect use and typical use, reflecting how hard a method is to use. I don't think that's the main source of the gap. That is one of the sources of a gap. But main sources of the gap in fertility awareness studies is this behavior intention gap. And it's not how hard it is, it's how motivated are they to avoid, I think. If a couple has sex on a fertile day without planning it in advance and gets pregnant, is that a negative or positive outcome? And do all couples want to plan their pregnancies in advance? These are things that need to be addressed. So I'm going to skip ahead because I'm running out of time. I'm going to mention that in our systematic review, we do plan to do some follow-up studies of some of the studies that we've looked at actually do examine the impact of the demographics, reproductive history, and motivations on the pregnancy rates. To me, that's more important than just the pregnancy rates themselves. And so that's hopefully the next paper. We're also looking at pregnancy rates in breastfeeding women and satisfaction and continuation. I'll say that we do have need for more studies. I do think we can recommend methods with confidence that they can be effective, but I do think we have a lot more to do to look at how the motivational relationship and reproductive factors impact pregnancy rates and acceptability. And I want to close with this. I do think for a Catholic healthcare system that wants to incorporate this as part of the Catholic mission, part of the Catholic identity, one fertility awareness-based method does not fit all. There's a variety of methods, as you've heard, and there are decision tools that are in development. FACS is developing one, and they're going to test it in a study before they use it, which kudos to them. They're not just putting it out there. And so there are decision development tools to try to help couples figure out which method might fit them the best. I think that if you're going to offer fertility awareness-based methods in a health system, you should use the ones that are evidence-based. You have to make your own judgment about how far can you stray from the original study in terms of service delivery and teaching and still rely on the original study. But you should use evidence-based studies that are methods that are peer-reviewed. And the evidence should be presented to patients and clinicians with the appropriate context. And we do need more research in this area. This is not something that we can say, oh, we know that works and we don't have to do any more studies. And maybe I have a bias because I'm a researcher, but I think that is a true statement. So thank you.